All right, why don't we get started? That's a little after 12. I'm sure others will hop on as we go along, but thanks for joining our next um, webinar from the Boston Lymphatic Center. We're going to discuss obesity-induced lymphedema. I'm going to start with just a little bit of background of the interrelationship between adipose tissue and lymphedema. Then Dr. Amanda Powell from Lahey, who's an obesity medicine specialist and runs their group there, will give us an update on some of the new medications and overall approach to obesity management, which is rapidly evolving, which has been an excellent resource for our patients. And then our therapists will go through a bit of their approach to body composition and management of patients, specifically with massive localized lymphedema. So just to start, we know there's a clear link between adipose tissue and lymphatic function. This is a nice slide that looks at the different pathophysiology of lymphedema versus lipedema. Again, two very different processes, but I like this slide because it shows the difference between the two. And that with lymphedema, it really starts with that accumulation of interstitial fluid, that lymphatic fluid that leads to an inflammatory immune response, the deposition of extracellular matrix remodeling, fibrosis, and eventually subcutaneous adipose deposition. And this is why liposuction is utilized for certain patients with significant increased limb girth from lymphedema. Lipedema is really the opposite. It probably, though we don't know a lot about it, starts with the deposition of adipose tissue and then kind of works backwards with maybe end stage or later stage leading to fluid deposition. But we know there's a clear link between adipose tissue and lymphatic function that's not very well elucidated at this point. We could see on MRI that we do for our patients that we're considering for surgery, this is someone's normal limb, this is their abnormal limb, and you could see this white here is significant increased adipose deposition in the affected limb. And then this is on autopsy, obviously, of a patient that had lipedema. You can see that the fat looks different in terms of it's lighter, but much, much more significant in the affected limb compared to the normal limb. So this was a nice study demonstrating the abnormal lymphatic function in patients with lymphedema and obesity. This was done at Children's Hospital through our colleague and collaborator, Dr. Aaron Green, from a few years ago. And they looked at lymphoscintigraphy, and the black is abnormal lymphatic function. You can see there's a clear trend as you get a BMI over 50, and then really beyond that, significant abnormal lymphatic function. Those numbers get to be a bit small as you get obviously to BMIs of 80s or nearly 100. But it's almost a guarantee that if you get a BMI over 60, you're going to have some degree of lymphatic abnormalities. And this is just demonstrating a patient with a BMI of 36, and then as they walk up, you can see the more significant abnormalities in the lymphoscintigraphy here on the bottom. We see a variety of different presentations of obesity-induced lymphatic dysfunction. I think it's probably, though it's not so well defined as, for example, breast cancer-related lymphedema, it's probably the most common cause of edema that we see in the lymphatic medicine clinic. The majority of patients are not going for surgery. Often these patients have multifactorial lower extremity edema due to chronic venous hypertension, maybe a little diastolic heart failure, and then the second hit of lymphatic dysfunction on top of it. So you see, certainly here, this patient has large lobules consistent with massive localized lymphedema, where here you have a patient with more kind of traditional lymphedema in the setting of obesity, maybe a little bit of lipedema as well, but has edema into the foot, but not the classic skin changes of venous disease. Here, this patient has more phlebolymphedema, so the combination of venous disease due to chronic hypertension in the setting of obesity, some lymphatic dysfunction as well, and you can see the positive stemmer sign. So again, I think it's clearly underdiagnosed, particularly in the significantly obese patient population, and I think it's by far the most common cause of lymphedema that we see at this point without another clear, obvious secondary hit. So I'm going to leave it at that because honestly, there's not much we know about this. It's still evolving, but there is clearly a connection. So I'm going to stop and let Dr. Powell take over and give us an update on the medical management and focus of obesity for these patients.
Thanks, Brett. So I just want to talk about sort of some of the current treatment options for obesity. I think that there's so much information in the news as to what the treatments are. And I think most patients come in wanting treatment for Ozempic. And so I think it's helpful to go over what the treatment options currently are. The most important thing, and you guys have touched on it around our breath.
Sorry, Mandy, before you head, your screen's not popping up, your slides.
Oh, it's not?
I might have kicked you off when I was sharing.
Let me just try again. I'm sorry. Let's see if I can do this.
I can also bring them up on my end if
No, that's okay. Let me see. You getting it now?
Great.
Okay. Is it big enough or do you want me to go bigger?
No, that's fine.
Okay. So I think what's important is just in general, because we understand why we treat obesity as a disease outside of the lymphedema, and critical to understand is that obesity has more than 200 complications, and it sort of hits every part of the body. And so it becomes incredibly important that we treat obesity as a chronic disease rather than a cosmetic issue. And more importantly is that when we do treat obesity, we can see substantial improvement in many of these comorbidities with fairly modest weight loss. So when you look at this slide, what you can see is even at a 0 to 5% weight loss, patients can have improvement in blood pressure, which you talked about as a contributing factor to lymphedema, elevated blood sugars, diabetes, and as you go along with more significant weight loss of 5 to upwards of 15%, you start to see marked improvement in more serious diseases like fatty liver and fibrosis, diabetes, cardiovascular disease, sleep apnea, as well as remission. With the newer drugs we're going to talk about, you'll see more improvement in cardiovascular mortality. And actually with heart failure, the newer drugs, there's plenty of data on these drugs and heart failure coming out. We're not going to talk about all the different treatment options because I think given the current landscape of obesity treatment, where effective therapy really falls to the bottom 3 drugs here, which is the GLP-1s. So my only focus today is while there are oral therapies, the data on the oral therapies fall more in the 5 to 10% weight loss range. And where we are today is treating patients obviously more aggressively with more effective long-term solutions that have other benefits outside of just weight loss alone. So GLP-1 agonists are the most common drug that we're using today in obesity. These drugs are known as Trulicity, Ozempic, Mounjaro, Saxenda, Wegovy, you name it. There's lots of different drugs on the market. We're going to talk about the ones approved for obesity. But essentially, GLP-1 is a gut incretin hormone, and it has a meaningful impact throughout the body. So the GLP-1 receptor is found in multiple areas of the body, including the brain, the stomach, the intestines, the liver, and then the heart. And these impacts of GLP-1 go far beyond just weight loss, but in the brain, there's neuroprotection. It decreases appetite through various neurotransmitters. GLP-1 delays gastric emptying, which leads to why patients will feel full when they take the medication. It has marked improvement in diabetes because we get increased insulin, improved beta cell proliferation. We get increased insulin secretion and decreased glucagon, and improved insulin sensitivities uptake, particularly in the muscle. As well as there's now a lot more data on what GLP-1 agonists are doing in the heart in terms of cardioprotection and improving cardiac output and heart failure. So what exactly are they? GLP-1 is derived from a pre-proglucagon gene and is cleaved into a GLP-1. It's secreted from the endocrine L cells in the intestine in response to nutrients. So when you eat, GLP-1 is naturally secreted and is then degraded by a peptide called DPP-4. And as I said, it has multiple effects, this GLP-1. The most prominent one that we see relative to weight loss is the delay in gastric emptying. And by making the stomach empty slowly, we make people feel more full, so they aren't able to eat as much. There's also a profound effect on what people now call food noise, so how it impacts on the brain, the GLP-1 receptors in the brain. It is thought, although not proved, that basically what GLP-1 in the brain does is it helps people feel full, and it gets at some of the sort of what we call food noise, or the thinking about food. It changes the way people think about food globally. The most common injectable that you may have heard about is called semaglutide, which has 2 names. It's known as Ozempic and Wegovy. Semaglutide for diabetes is called Ozempic, and semaglutide for obesity is called Wegovy. They are interchangeable drugs. They're the exact same pen. They have different stickers. So semaglutide was originally approved for type 2 diabetes at doses of 0.25 to 1 milligram. The benefit of the drug, and when it was originally approved, was for diabetes, getting an average of an A1C improvement of 1.5% and about 10% weight loss. As you go higher in the dose, what happened is it was discovered the weight loss was so great in diabetes that it was looked at for obesity, and the dose was bumped up to 2.4, and at higher doses, we see even better weight loss. So patients on treatment with Wegovy at 2.4 milligrams are losing upwards of 16% weight loss. And here's just in the New England Journal of Medicine, you can see one of the landmark studies in 2021, which showed that the average weight loss relative to placebo was about 16%. So this was the first drug to really markedly change the landscape in obesity treatment, because all of our drugs prior to this particular medication really didn't get us more than 10% weight loss. And so as we look back to that first chart, what we can see is that higher weight loss leads to better long-term benefits for the other comorbidities. And semaglutide really was the first drug for us that had profound benefits well beyond weight loss. Most importantly, there are cardiovascular outcome trials that have been done in semaglutide. And in this particular study that was also, I believe this was the New England Journal as well, there was a study done in patients with pre-existing cardiovascular disease, looking at over 17,000 patients. They were non-diabetics, and they were put on semaglutide versus placebo. And the composite endpoint was looking at major cardiovascular outcomes. And I'll show you on the next slide, but the absolute risk reduction was 1.5% with a number needed to treat of 67. So in this select trial, it was a landmark study showing that patients on semaglutide were able to reduce the risk of major cardiovascular outcomes by 20%. It also reduced the death from any cause. It reduced worsening heart failure, kidney failure, the risk of diabetes by 73%, and improved blood pressure and triglycerides. The data from this select trial was so impressive that 2 weeks ago, the FDA approved the first treatment to reduce the risk of serious heart problems, specifically in patients who are adult or overweight. So this is the first drug that we've ever had where we are now recommending it as a cardiovascular risk reduction medication in overweight or obese patients. So this is profound because in the history of obesity treatment, everybody's always been very scared to treat obesity, worried about what if we cause other problems. We give people sort of phentermine or other drugs. People worry fenfluramine or fen back in the 90s. We cause cardiac problems. So it's a major change in the way we're taking care of patients with obesity, is that we're looking for improvement in other disease outcomes. And so on March 8th, the FDA announced the approval of an additional indication for Wegovy, which is also Ozempic, for patients who are at high risk of major cardiovascular events. And it's approved in patients who are above the age of 12. The nice part about this approval is in Medicare patients, which is the hardest patient population for us to treat and get coverage for drugs, is Medicare is supposed to start covering Wegovy for overweight and obese patients with cardiovascular disease or risk of cardiovascular disease, which is profound for us because the Medicare patient population has historically been very hard to treat because their coverage issues. Another medication that came out a couple years ago for diabetes, but in November of this past year for obesity, is a drug called tirzepatide. This is the first dual agonist, which is also an incretin hormone, just like GLP-1. What it is it's a combination of two peptides, GLP-1 and GIP, and it also does the same thing as Wegovy or semaglutide, but it has better weight loss. So what you can see here is patients who are given tirzepatide, or otherwise known as Zepbound, for weight loss. They have substantially more weight loss, and in the intention to treat trial, actually patients on Zepbound or tirzepatide actually achieve up to 25% weight loss. So in comparison to Wegovy at 16%, this newer dual agonist is actually getting us upwards of 25% weight loss, which is the first drug to start to rival the effects of bariatric surgery. So again, in the world of obesity treatment, it's game-changing because our goal in time is to be able to medically treat a patient as effectively as we can in a surgical patient population, and our newer drugs are starting to get us there. So this is just the data on the dual agonist, the SURMOUNT trial, just to show you. The patients are dosed anywhere from 2.5 to 15 milligrams of tirzepatide. The drugs, all of them, by the way, can cause some nausea, heartburn, constipation, diarrhea, and other GI side effects. The beauty of these newer dual agonists is actually they're not only more effective for obesity, but they actually have fewer side effects. So when we're making decisions on what to put a patient on, these newer dual agonists are actually much easier to tolerate, and they happen to have better weight loss. So in the vein of where we're going, we're choosing to choose these dual agonists over the single agonists when we can. How do they stack up from diabetes? You know, when we compare Ozempic or Mounjaro compared to tirzepatide, the dual agonists, again, not only from a weight loss perspective, they actually also do much better in terms of diabetes control. So on the 3 left columns, you'll see 3 different doses of tirzepatide. Again, sorry to go back and forth, but most people do know the generic names of Zepbound and Mounjaro. But on the 3 left columns, you'll see the comparison that an A1C reduction in the 2 to 2.5 compared to 1.8. The baseline reduction in body weight is almost double if you compare Ozempic versus Mounjaro. And participants achieving an A1C under 7% is upwards of 90%, which is incredibly impressive, as well as those achieving an A1C under 5.7% is almost half. So these drugs are not only really, really good for weight loss, they also are incredibly powerful for diabetes. The nice thing about that too is in the vein of treating a diabetic and being able to get a patient off insulin and onto a single or dual agonist is also very powerful because insulin is so weight promoting. So when we think about treating our diabetics, we try to get them off insulin, and now we have powerful drugs that will allow us to get them off insulin and all the complications associated with that. And just finally, this is a chart showing all the current weight loss medications on the market. And on the far right, you can see that historically, many of our drugs, oral therapies mostly, got in the vein of 3 to 10% weight loss. And with the addition of the injectables, we've started to achieve upwards of actually 25%. So in this, it says 21%, and that's all completer data. But if you look at intention to treat with people who actually did it and complete it, we see closer to 25%. So I know we didn't have a lot of time, and I was given sort of like 10 minutes to go over medication, but just sort of in summary for GLP-1s in particular, but most important, obesity is a disease that requires medical attention and treatment. Without treating the disease of obesity, patients will likely develop many weight-related comorbid conditions. It's important to address the issue with patients and engage them in the treatment pathways. And really importantly, there are many treatment options available with benefits that go well beyond simply reducing weight, but improve glycemic control and cardiovascular outcomes. So there's in general, there's very few patients that don't benefit from these drugs. Not to say we're going to put everybody on it, just to understand they are expensive. Some insurances don't cover it. There are shortages. So the logistics of it today are somewhat challenging, but when we can get a patient on it, you can see substantial benefits and the patients feel remarkably in control and feel so much better.
Thanks so much, Mandy. That was a great overview. And I'll say, in our patients that are coming back after having dramatic weight loss, that are primarily obesity-induced lymphedema, some of them are having complete resolution of their edema, which really was not, possible even like 5 years ago when we were seeing these patients. So we're seeing dramatic weight loss and benefits in terms of their edema to the point like they don't even need to follow with us anymore. So that's a great overview. Really appreciate it. We'll switch over to the therapists now and get their perspective. Katrina and Emily, take over.
Sorry, technical difficulties. Can everyone see the screen okay? Okay. So first, we're just going to talk about some therapeutic management for patients with lymphedema and obesity. First, we always just take some measurements for patients. We take circumferential measurements, and then we have some bioimpedance testing that we do here. We understand that not everyone has the bioimpedance testing. We do feel fortunate to have that, but we do use that to kind of help guide our treatment plan for patients. So we have what's called the in-body and then the SOZO bioimpedance. We also just look at kind of different compression strategies. So kind of looking at their body habitus, their blood mechanics, and kind of seeing what will be best for compression wise for a patient. Assess if they need CDT, do that means to come to the clinic every day. And then, are they focusing more on weight loss right now? So, as you can see, we have the lymphatic medicine team here to kind of refer to a weight loss clinic or to have them discuss with their PCP to kind of focus on the weight loss there. And then other just exercise recommendations. Obviously, this is very patient depending, but trying to incorporate that into their routine as best as they can. Elevation as able. Obviously, we know this isn't helpful for every single patient depending on the staging of the lymphedema, but if it helps, then trying to incorporate that as well. And then also trying to get them a pneumatic compression pump. It's good to kind of have a rep that you're close with to kind of see if you can get that for a patient, because that can help them significantly as well. So we're going to go a little bit into the bioimpedance and how we can look at the body composition, and how we can use those to kind of direct our therapeutic management. Again, I know not everyone has these, but we do feel fortunate to have them, and we can use them. So here's this is called the in-body. So it kind of gives a full body composition breakdown. It's a really nice handout we can give to the patients as well. They can take it with them. So it kind of goes over their weight, their muscle mass, their body fat mass, and then obviously their BMI. And it kind of has a good fluid component too. So as you can see, it's a little hard to see, but they have these kind of dashes here with the shaded gray, and that's the norm for a patient's height and weight. So yeah, we go through that. So I'll kind of break it down here. So the first section you look at is just the muscle fat analysis. So it goes over the weight, how much muscle mass, and how much body fat mass. It's overall helpful to look at these because, you know, if patients trying to lose weight, you know, it's kind of important to hopefully kind of keep their muscle mass at a good range, and then hopefully decrease their body fat mass. And then here's just the obesity analysis. So it looks at the BMI and then the percent body fat. This is kind of nice because especially, you know, obviously we know that BMI just incorporates their height and weight, and we use that a lot in our treatment, but it is also helpful to kind of give context to their BMI and say like how much of it is percent body fat and what are some goals that we can kind of try to use to kind of work on trying to decrease their percent body fat. To just kind of give some context, which is helpful. And then this kind of breaks down how much extracellular water versus total body water we have in each limb and trunk. So there's a ratio here on the side. It's called extracellular water to total body water ratio. Basically, the typical range is 0.36 to 0.39. So as you can see for this example patient, you know, both legs and the trunk are above kind of that typical range. So it's also helpful to look at, you know, depending after we put compression or weight loss to kind of look at these numbers over time and again see if they decrease, or you know, that's what we hope. This looks at the visceral fat. So basically visceral fat can kind of can be cause for cardiovascular disease, diabetes. So we just want that to be kind of below that 100 line. And for this patient, you know, she is overweight, but actually her visceral fat is in a good area, which is kind of interesting to note, just because she is overweight. And then this is just another way to use the body composition. This is through the SOZO bioimpedance. It kind of has a similar breakdown than to the in-body, but it kind of goes over the total body water, and then obviously the extracellular fluid, which would be lymphedema, and then the intracellular fluid. This breaks down muscle mass and fat mass. And so as you can see, there's like the mean that's basically right in the middle. And then for the fat mass, there's like different ranges. So, you know, this patient is in like the high range for fat mass. And then over here on the side is just for their BMI. And obviously you can see it's like the green is healthy, overweight, and then obese. And then this is a pretty cool slide too, because it kind of shows the muscle mass and fat mass over time. So this specific patient has been with us for a while, so you know we've been able to kind of track his numbers you know, for a while now, so it's kind of nice to see, you know, where this patient has landed.
So I'm just going to speak a little bit about MLL, or massive localized lymphedema. Obviously, in patients who are just happen to be obese and also have lymphedema, there are just a lot of considerations of what your treatment is going to entail, but we always want to incorporate increasing a patient's activity level in general with just obesity. But this is kind of tailored to that MLL patient who walks through your door. Oftentimes you're wondering how you're going to manage this patient. How am I going to bandage this patient, et cetera? So just we're going to spend a couple more minutes, the last few minutes, on MLL. So MLL just kind of has that classic disproportionate lobular collection of the soft tissues with edema. There are a lot of mobility implications. A lot of times the patients have a lobe like in their upper medial thigh, making it difficult for them to walk or mobilize. There are oftentimes skin changes and potential for infection, wounds, things like that. It is most common in patients with obesity. I did say a lot of the times it's in the upper medial thigh, but it can also affect the pannus, the lower leg, and the upper arm as well. And there are a lot of barriers to conservatively managing these patients, which I'll go over kind of in a case. And there are also barriers to surgical management. So a lot of people walk through the doors and they're like, can you just cut this off? And so there are risks and considerations for that as well. So for conservative management of MLL, our gold standard is always going to be CDT, but there are a lot of barriers when it comes down to that. So bandaging a patient like this is really difficult based on the size differential between the majority of the leg or the arm in question and the rest of the lobe. So you kind of have to get creative with bandaging techniques or kind of your underlayers of foam or whatever you're utilizing. Sometimes we use an inelastic wrap or a different modality to kind of utilize with our CDT. Positioning for these patients is huge because a lot of the times we can't bandage or can't get these people into a garment. So we're really doing a lot of education on ways that they're able to prop that lobe up or position at nighttime and kind of get some good drainage out of that area in lieu of traditional CDT. Like I mentioned before, increased activity level is huge for these patients. So we want to incorporate that into our education and our treatment as well. And then really the cornerstone to all this is your long-term containment. So after you've done all this education or a course of CDT, you want to make sure, as always with any lymphatic patient, that you have a good long-term plan for them. So a lot of the modalities that we focus on with a patient with MLL, MLD, oftentimes you're going to be needing to focus on techniques with your MLD that incorporate or manage your fibrosis or your kind of tougher areas. And oftentimes with downward pressure, you can get some good drainage that way. Again, being creative with your multi-layer bandaging components or using something that's pictured here on this slide, which is the lobe kit by Circade. It's like the inelastic wrap. It's able to accommodate and give good compression for these tricky areas. That's another option. You can use texture underneath a pump or your bandages to kind of soften at these more fibrotic areas. And you're also going to apply a varying extent of wound care, or skin care, or potentially wound care, depending on the patient's status. You'll also probably need to utilize some custom garments in whatever capacity that you end up with, whether it be an elastic wrap or a flat knit garment. You can get creative with the way you're layering those garments as well to get kind of good coverage and make it easier on the patient to don and doff. Quickly, I'll just go over this quick case, and I find this patient interesting for a lot of different reasons. Obviously, this is a pretty unique and profound case, but you'll notice in 2020, this is what the patient's leg looked like. And then in 2022, there was still no therapeutic intervention. This patient had just lost more than 200 pounds. And you can notice at the kind of proximal end of that edematous area of that MLL, he's got some decongestive benefit there just purely from weight loss because he's got a lot of wrinkling of the skin. You can notice that there's been some decongestion there just with the weight loss alone. And then a follow-up here after about 6 weeks of CDT. So he's come a long way. And then there are excisional procedures for these lobular edemas. And just from a CLT or a therapeutic perspective, we want to follow these patients. There's an extensive incision in an area that's really delicate and oftentimes congested with fluid. So you want to make sure that you're kind of doing your best to educate the patient, maybe get them in a garment or wrap them, making sure that we get good wound healing and we reduce risk for infection and wound dehiscence.
This is a quick case on a patient that had a surgical excision of their MLL. So as you can see in 2019, you can see that he had an ML on his right upper thigh. He actually had a crush injury in 2017. And so then he developed that swelling afterwards. Basically from 2019 to 2022, he had conservative treatment. So different types of compression, elastic wraps, custom garments. And then they also wanted to ensure that he could lose a little bit more weight before they would perform surgery on him. So his goal weight for surgery was 300 pounds, which he was able to achieve. So then he had the surgical excision of the MLL in October of 2022. And then after that, he was closely followed by the therapist and with multi-layer bandaging, especially because he had some surgical drains, so working around those as well to kind of help maximize the outcomes of the surgery. And then as you can see here, the photos on the left, that's actually just from this month. This is kind of the outcome of the surgery. Now he's in custom flat neck garments that he wears, very religiously, and he also has continued to lose some weight. So I think it just kind of goes to show that this is kind of a success story for surgery, and with patients that are very compliant and then can follow through with compression and all of that after getting surgery is hugely beneficial. So it's definitely it can be done, but it has to be the right patient that is able and willing to kind of put the work in. And that's all we have.
Yeah, I know we're kind of a little bit over, so we want to respect everyone's time, but.
Yeah, thank you. That's a great overview from a therapeutic perspective. And I think the presentations kind of show the multidisciplinary nature for managing these patients. I'll say a fair amount, though certainly not all, will have some diastolic heart failure as well. We do not generally use diuretics for lymphedema, but as our older obese patients, their heart tends to get stiff and they have some component of diastolic heart failure as well. But obviously the heavy lift is from the obesity medicine group and our lymphatic therapy group in terms of getting these patients under better control. So if there's any questions, certainly you can raise your hand. I can unmute you, or you can put it in the chat. We'll give people a few seconds, and if not, we'll wrap up. And also always feel free to email me. I think you have our email from the invitation for the webinar. And if you have ideas or would like to hear other topics for upcoming webinars, just let us know. Otherwise, we'll hopefully see everyone in a few months. Thanks so much. Have a good afternoon.